Welcome, everybody. It's another Expert Talk series, and it's your extended family all getting together. As you know, research on ALS is continually advancing, and at Everything ALS, we are dedicated to uncovering new discoveries, supporting early detection, and working towards a cure for ALS. Would you like to participate in our speech study? The goal of the speech study is to enhance the diagnosis and prognosis of ALS. We are seeking participants to provide 5 speech recordings, each lasting 15 minutes, once a month, for a total of 75 minutes over 5 months. It's a pretty doable, I would say, for everybody. Please, if you can consider it, jump in. We invite both healthy individuals and those diagnosed or suspected of having ALS to join us. To enroll, please visit everythingals.org, speech project, and fill out the form. You will find a link to that in the chat. And guess what? We're really working. We have one more that we're recruiting for. It's the asymptomatic gene carrier study. If you're a gene carrier and asymptomatic, we are interested in if you're interested in remotely monitoring your speech, cognition, and motor skills, please visit everythingals.org, asymptomatic study, and we'll have a link to that also in the chat. I have something very special right now to share with each of you. We are starting a new program called Office Hours, ALS Nutrition, and Everything ALS app support. And it will be every other week. And we have we'll have a link here in the chat for you to look at that. And some of the things that will be talked about is the role of different types of fats, how to store energy, strategies for gastrointestinal symptoms, what's a good protein, and a number of other things like that. So you can get your questions answered about the app, and you can learn some vital information that each of us has to know about. So thank you all for coming. And with that, I'll turn it over to you, Christian.
Thanks, everybody. Christian Rubio here, Executive Director here at Everything ALS. Welcome to another Expert Talk, as McFinn has been welcoming us. A couple of housekeeping items really quickly. As always, we have an Expert Talk tonight that'll be presented in full by our speakers. And then after, we'll have an open Q&A session for the audience and all of our special attendees here to be able to interact with them directly and ask your questions directly. You can use the chat function to ask your question anytime. And my teammates tonight, Natalia and Alex, will be handling the Q&A with you at the end. So without further ado, I'd like to introduce today's topic, Neuromuscular Rehabilitation and ALS Recovery, an update on Tofersen for SOD1 ALS, and broader implications for ALS treatments. Our guest speakers tonight are Dr. Sean E. Smith, and also Beth Hughes, both from Washington University. It's my pleasure to introduce them. Dr. Sean Smith is a board-certified physiatrist and specialized training in neuromuscular disorders. He holds the position of Assistant Professor of Neurology in the Neuromuscular Division at the Washington University School of Medicine in St. Louis. Following his cum laude graduation from the University of Delaware in 2003 with a degree in nutritional sciences, Dr. Smith pursued a master's degree in exercise nutrition at the University of Buffalo in 2009. He subsequently obtained his medical degree from St. Louis University School of Medicine in 2015. Completing a residency in physical medicine and rehabilitation at Washington University Barnes-Jewish Hospital, Dr. Smith further advanced his education with a master's degree in population health sciences in 2020 from Washington University. In 2021, Dr. Smith completed a fellowship in neuromuscular medicine at Washington U, and notably, he was the inaugural ALS Clinical Trials Fellow in 2022 under the mentorship of Drs. Timothy Miller and Robert Buccelli, co-directors at the ALS Center at Washington University. Currently, Dr. Smith holds a leadership role as a director of both the WashU ALS Clinic and the Tofersen Clinic. He brings his expertise in rehabilitation medicine to the multidisciplinary ALS care continuum, focusing on care coordination, symptom management, and optimizing patient functional independence and mobility. He serves as an investigator in several high-impact clinical trial studies, focusing on innovative treatments using antisense oligonucleotides, or ASOs, in different types of ALS and other novel therapeutic strategies. Joining tonight also is Beth Hughes. Beth is a board-certified neurologic clinical specialist as part of the team, and she's assistant professor at the Washington University program in physical therapy. She earned her Bachelor of Science degree in exercise physiology in 2016, followed by her doctorate in physical therapy in 2018, both from St. Louis University. Dr. Hughes has extensive experience in both outpatient and inpatient neurologic rehabilitation and achieved board certifications as a neurological clinical specialist in 2022. In her current role, she practices in outpatient neurologic care to a diverse range of patient populations and is the principal physical therapist with the integrated multidisciplinary ALS clinic at Washington University School of Medicine. Dr. Hughes teaches within the neurologic content at Washington University program in physical therapy. Dr. Hughes is currently focusing her work on advancing knowledge translation and rehabilitation to improve quality of care within the ALS community. She is dedicated to advancing the integration of clinical care, education, and evidence-based practices in the treatment of neurological disorders with a deep commitment to improving patient outcomes. It's really with great pride we're able to welcome both tonight. Without further ado, I'm going to welcome Dr. Smith, who's going to present first, and then Dr. Hughes. Thanks for joining us.
Yeah, thank you. Thank you for having us. It's a privilege and an honor to be asked to speak. And this is an exciting topic, really enthusiastic about, and not sure that a couple of years ago that we would have had the data to present to show that people are getting better in SOD1 ALS with the advent of Tofersen and kind of what we're doing here to help patients optimize the benefit of the treatment. So let me share. Okay, everyone can see? All right. All right, so a brief outline. I'm going to go over a few slides of SOD1 ALS and a little bit of background on Tofersen, the results of the Valor study, which was the placebo-controlled trial that tested Tofersen, and then the open label extension, and share with Beth our findings in the SOD1 ALS rehab study that's an ongoing study here for our participants who are receiving Tofersen combined with neuromuscular rehab. And then some next step ideas on kind of the broader implications of our findings and how that relates to everyone with ALS. And then the question and answer session. All right, so not too in depth, but the genetic landscape of ALS is that 90% of patients are what we call sporadic or apparently sporadic, meaning that there's no clear cause, no genetic finding that's associated with an increased risk of ALS. About 10% is familial, or maybe more accurate to say genetic. And of that, C9orf72 is the most common cause of genetic forms of ALS. And SOD1 or SOD1 is about 20% of familial or inherited cases. And overall, SOD1 ALS is about 1 to 2% of all cases with ALS. So one of the more common genetic causes, but still relatively rare in comparison to all forms of ALS. So SOD1 stands for superoxide dismutase 1. And if we look at here, panel A, it says no SOD1 mutation. In the gene, we have DNA that gets transcribed to a string of proteins called or a string of coding called mRNA, which is then translated into a normal SOD1 protein. In patients with an SOD1 mutation in panel B, labeled untreated ALS. You can see in the DNA there's a change noted by the red highlights here, that there's an SOD1 mutation, and that gets transcribed into an mRNA that includes the mutation. And when that gets translated, it gets translated into a toxic SOD1 protein. And so usually most individuals have what we call a heterozygous mutation, meaning there's two copies of the gene for SOD1, and one of the copies carries the mutation. And so patients can still make normal SOD1 protein, but in addition, the toxic form builds up, and that is what is causing the dysfunction and eventual degeneration of the motor nerves. So tofersen, or Qalsody, it's an antisense oligonucleotide. It is delivered via lumbar puncture and delivered to the cerebrospinal fluid. And so if we look at panel C, it's the ASO here, representing tofersen. And with tofersen treatment, what happens is the DNA with the SOD1 mutation continues to be transcribed, but at the level of the mRNA, the tofersen binds, and it specifically targets this SOD1 mutation mRNA, and activates an enzyme called RNase H1, which mediates degradation and the breakdown of the mRNA. And so you get a reduced production of the toxic SOD1 protein. So that's kind of the simplified view of how tofersen works. And I want to spend a minute on a topic that is still under a lot of research, but has been very helpful in regards to diagnosing and monitoring ALS and other neurodegenerative diseases, which is neurofilament. Neurofilament is, or neurofilaments are proteins that help maintain the structure of nerves and assist in providing normal function of the nerve. In disorders like ALS, where there's nerve degeneration, what happens here, this is a depiction of a motor nerve, is there's breakdown of the nerve, and the neurofilaments start to break down here, and they can spill out into the spinal fluid and also in the blood. And we can measure this in the serum, and it's a marker of the nerve breakdown. And there's correlation to disease progression and severity, and there's some limited information on prognosis as well, measuring the level of serum neurofilament. And so this is plays a key part in the research study for tofersen and its approval by the FDA. So the VALOR study was the initial testing of tofersen in a placebo-controlled trial. Panel A here is the total SOD1 protein concentration in the spinal fluid. And so, as I showed you previously, that tofersen causes a reduction in the SOD1 protein, specifically targets both proteins. So you get a reduction in the normal SOD1 protein and the toxic SOD1 protein. But that's what is shown here. The red is called the early start, so they got the treatment right at the beginning. And the blue is the placebo portion of this study that lasted 28 weeks. And after that, it was the open label extension. And at that point, those who were in the placebo group were started on tofersen. And what you can see is that there is a reduction in the SOD1 protein when the group that had the early start compared to the placebo. And then In the extension, open label extension, you can see with the start of tofersen, that group as well had a decrease in SOD1 protein. And if we look at panel B, the concentration of the plasma neurofilament, in this case, neurofilament light chain, for the early start tofersen, there was a significant decrease in the concentration of the neurofilament up to 28 weeks, where in the placebo group, in the blue, had basically a stable or maybe a slightly increased level of neurofilament over that period of time. And the open label extension, what we can see is when those individuals received tofersen in the open label extension, they ended up having a decrease in their neurofilament as well. And then there was maintained decrease in neurofilament, plasma neurofilament in the early start tofersen. And if we look at the ALS FRS total score, the ALS functional rating scale, so it is a metric that we use to determine function. It looks at 4 main domains: fine motor, gross motor, bulbar function, chewing and swallowing, and breathing function, where the higher score at a 48 indicates retained function and lower scores indicating a more functional decline. What we see is that at the 28-week mark, there was no significant difference between those who were started on tofersen versus the placebo. But there was a slight decline overall. And when we look out to the 52-week mark, in the open label extension, we start to see that there is a difference between those who were started on early tofersen compared to the placebo. So in this case, the arrow helps us and lets us know that the worsening is towards the lower end of the graph. And with strength, it was measured by handheld dynamometry. And what we see here is the early tofersen continued to have continued decline in muscle strength to 28 weeks. And then looking outward to week 52, there tended to be stabilization of strength. And we kind of see the same pattern in the placebo and delayed start tofersen. They had worsening strength in the placebo part. And then when they started tofersen at the 28-week mark, there was a continued decline and then somewhat stabilization out to week 52. And just to summarize the VALOR and open label extension data, the VALOR did not achieve statistical significance for the primary endpoint, which was the change in the ALS functional rating scale at week 28. But there was that reduction in total SOD1 protein and spinal fluid, and tofersen was associated with the reduced plasma neurofilament. But overall, as we look out to that 1-year data, the 52 weeks, there were trends favoring that tofersen provided benefit, particularly for muscle strength, respiratory function, and quality of life. And there was approval by the FDA in April 2023 based on the reduction in plasma neurofilament as a reduction in neurodegeneration. And so at this point, that neurofilament seems to be a pretty good biomarker of potential treatment response in that treatments that lower serum or plasma neurofilament are likely having some positive benefit on ALS progression and neurodegeneration. And we published an article in January of this year of our experience with treating patients initially in the Expanded Access Program, the EAP, for Tofersen, and then clinically once it was approved. And we had 7 patients initially. Currently, we have 9 that are receiving Tofersen, and I just want to point out a few things on this table. One is they all had the SOD1 mutation. They were all different variants or different mutations, and only 1 patient had a family history of ALS. And so 6 out of the 7 were what we would call apparently sporadic until they got the genetic testing that showed they actually had an SOD1 mutation. And so we strongly encourage patients with an ALS diagnosis to at least get SOD1 testing, even though if they don't have a family history or other known family members with ALS, because it's possible that there could still be an SOD1 mutation, and there's a treatment for it. The other thing I want to highlight is we had 2 patients that were right about a year from their onset of weakness, and there was 1 patient who was over 22 years of ALS that had started treatment. We looked at a number of things, the neurofilament in the spinal fluid and the serum. We measured the functional assessment with ALS FRS progression rate. We calculated an expected ALS FRS if the patient had not received Tofersen. And so we'll show you that comparison as a way to kind of measure or capture retained function. Measured strength, and then something called the FIM motor score, and then several functional outcomes that Beth will go over. All right. This is the change in serum NFL and the spinal fluid neurofilament heavy chain. And that's what you can see is in the first several months, there's a decrease in the serum neurofilament. And then this is sustained out for 1 patient up to 2.5 years. And we see the same thing in the spinal fluid, the neurofilament heavy chain, where after the first couple of months of treatment with Tofersen, there's a decrease, and then that's relatively maintained throughout the treatment course. And looking at the ALS FRS, all patients either had stable ALS FRS or had gained a point or 2. And what I want to show is this slide, which is the gray bar is the expected place where patients would be if they did not receive treatment with Tofersen. And so all patients, as the typical course with ALS, would be expected to have continued progression and loss of function. And so we did this to capture that there is retention of function, even though some of the patients did not necessarily show any improvement in function. And back to this table 1, just to highlight that all the patients had different rates of progression, and then they all had different types of treatment response in regards to the slowing. But all patients had slowing of their ALS FRS over their treatment period. All patients but 1 had increase in strength. Initial patient 1, who had 22 years plus of ALS, had some decrease in strength over the treatment period. Otherwise, there was varying degrees of improvements in strength. And I'm going to hand this off to Beth to discuss the FIM motor score and more of the physical therapy, neuromuscular rehabilitation aspect of what we're doing.
Thanks, Sean. Thanks, everybody, for having us here. I echo Sean's sentiment. It's exciting to be here. So I'll start with the FIM motor score. So the FIM score is basically a measure that we use in the rehab world to see in different areas of day-to-day activities how much assistance people need. So when we look at the basic premise of the scale is if you look at self-care activities, transfers, walking, we look at how much assistance you need, a little bit, a lot, and does that change over time. So this is one score that we measured just to see how that changes and how much assistance folks needed. Sean, you can go to the next one. And so again, typically we would imagine that the higher the score is, the less assistance someone needs, so more independent in their day-to-day activities. And so we measured this from the therapy perspective, and in typical what we see in clinic is that over time, folks need more assistance. So actually increasing, getting a higher score means that they're more independent with those day-to-day activities. So slight changes in the upward direction for everybody here. Go to the next slide. I think the biggest thing to really discuss is this change in the model of rehab that we're seeing with SOD1. So there's good evidence for the role of neurorehabilitation, and that includes physical therapy, occupational, and speech therapy. My background is in physical therapy, so I'll speak to that. But I do have colleagues working in speech and occupational therapy with these individuals as well. And in general, we typically focus on maintaining functional independence with this rapidly disease progression and monitoring changes over time to keep people independent, doing the activities they want and safe for themselves and if caregivers are needed. And so now that the work that Sean's group has done is seeing the disease stabilization, we've really changed our model in rehab to work with that disease stabilization and actually show improvements in function. So the way we've designed this program is that it's extremely individualized to each person that we've seen. It's goal-directed. So what's important to them? We do use outcome measures to measure their functional mobility and their independence, but it's still all their interventions are geared towards that person and their needs. And then we measure that over time and use those measures and monitoring to basically progress and change their programs. And we work on an interdisciplinary team. Go to next slide. So when we look at individualized neuro rehab, we kind of address, especially in physical therapy, three main areas. So functional mobility looks at someone's transferring status, their balance, looking at falls, and basically their ability to move independently, and if they need any bracing or orthotics to help with that. Aerobic capacity is looking at their cardiovascular fitness, so that includes their breathing, their endurance, stamina. Fatigue management is really big when working with those individuals with ALS. And then strengthening. So historically, strengthening has been hesitant to be used with ALS out of fear for overusing the muscles and causing more muscle breakdown. And so what we've been able to see with these individuals is not only are we able to do functional strengthening, but we've been able to progress them to add weights, to use neuromuscular re-education through STIM, using eSTIM, and then push people into higher intensities in aerobic capacity, putting them on treadmills, body weight systems, giving them home exercise programs where they can actually push themselves into higher and challenging intensities to see improvements. So those are kind of the main categories that we're targeting. You can go on to the next slide, Sean. The biggest thing is how we're monitoring. So we don't want to just give individuals programs that push them past their limits, that they're inappropriate. So we first go with the basics of vitals. So taking their resting heart rate, using the heart rate reserve is a measure of what their age is and what their resting heart rate. And then we can see kind of what their maximal heart rate would be based on that. And then we take percentages of that to determine if it's low, moderate, or high intensity exercise based on their heart rate response. We monitor their SpO2 or what's their oxygenation, and then their blood pressure pre and post exercise, so we can determine physiologically what's going on during that exercise, pre, during, and post, to how they're responding. Beyond the vitals response, we pay close attention to the rate of perceived exertion. So this is a scale you can It's hard to see the numbers, but you can see the color. So 6 is at rest, and 20 is giving the maximal exertion that you have. And so I use the scale with individuals from day one of educating of, I want to know how hard you feel that your body is working. Because sometimes how hard someone feels they're working doesn't always match with the vital signs that we're taking. So we want to take both of those things into account. And so we monitor whether it's a walking, transfer, strengthening exercise, how challenging does that feel to that individual? And that's a good gauge. I kind of tell people this is like my pressure gauge, like do we dial up, dial down, and how do we use that? And then the big thing over is monitoring this muscle overuse signs and symptoms. So I typically tell our patients is your body's going to tell you how you feel and if it was too much or too little. And so especially for those non-on Tofersen, we are really concerned with muscle overuse. And that means that the activity or exercise someone is doing can be causing more harm than good of breaking that muscle down. And the signs and symptoms that are telling of that is that after 48 hours of exercise, they continue to have muscle soreness, are more fatigued than on the daily day-to-day basis. They might notice increased fasciculations or shortness of breath and really just aren't recovering. So this is a sign that we used as we started to increase the intensity of exercise in educating these individuals with SOD1 on Tofersen, how to monitor that outside of therapy sessions, again, to decide if we wanted to dial up or dial down. And I think it also really drew in the individuals into their program in designing that of what works, what's too much, what's too little, and how do we gauge that? As you can imagine, we started fairly conservatively, going off current literature on ALS, and then and progressed based on these 3 areas of vitals, physiologically, what's happening, rate of perceived exertion, how is that person feeling during the activity, and then muscle overuse is how did they respond in the next few days to determine that progression. All right, we can go on the next one. And then we monitored over time with objective measures. So those, we measured that. So the 10-meter walk test is having someone walk for 10 meters. We measure the middle 6 meters. So you kind of have a ramp up and a ramp down if needed. And we measure their self-selected. So what's the comfortable walking speed that you walk on a day-to-day basis? And then fast speed. So if you needed to walk across a busy street or you needed to hustle, how fast can you walk safely? And we measure that in meters per second. And that's the 10-meter walk test basically assesses your walking speed in short distances, and is also a highly rated objective measure that correlates with fall risk. I'll go over that in a little bit. And then the timed up and go is similar in that it demonstrates a short distance walking, but it adds a little bit more by getting someone, so you time them from when they're sitting in a chair, they walk 3 meters around a cone and come back. So that adds a transfer in there and a turn, which can demonstrate some differences in the 10-meter to really show how someone's walking at home or in the community when they need to get up, walk to an area, turn around, and come back. And we are able to measure that against some age-matched norms. Go. So these are, so there's been 4 individuals that have been consistently being followed in our rehab, and being measured on a monthly basis. So the timed up and go, the slower, the more time it takes, the more that's someone has a higher level of disability. And so you want that timed up and go, the speed to be faster. So you can see that there's a significant change in all of these individuals. Patient 7 there doesn't show a huge change, but most average adults are about 8 to 10 seconds. So being at 6 seconds, he was already cruising. So we didn't expect a huge significant change over time. Anything greater than 15 seconds, that places someone at a higher risk for falls. So you can see that, especially with patient 3, that not only did they decrease their time to perform this test, but they moved themselves out of that risk for falls based on statistics. Go to that next slide. And then here's the 10-meter walk test. So reversely, faster, we want to see an increase in that speed. Like I mentioned earlier, this is another gauge for fall risk. So anything less than 0.7 meters per second places an individual at a higher risk for falls than others. I always tell my patient that doesn't mean you can't fall if you walk faster than that, but a lot of studies do demonstrate that it places you at a higher risk. But besides fall risk, we look for change over time. So 0.2 meters per second shows a minimally clinically important difference. And then also we look at community ambulation speeds. So typically, if someone is walking at speeds from 0.4 to 0.6 meters per second, they're going to be very limited limited community ambulation, or typically only ambulating within the home. Anything at 0.8 meters and above, this individual is most likely walking in the community. And then 1.0 and above, they're walking at more typical community walking speeds. So again, if we direct our attention to someone like patient 3, when he started physical therapy, the individual is walking at 0.37 meters per second. So that means he was really only ambulating within the home and using a wheelchair for all other mobility. And now with the measure that we have there at 0.7 meters per second, he's getting to the area where now he's starting to use that walker out in the community for a shorter distance. So, and same thing, you can look at some of the other patients like patient 4 demonstrates now getting into that community ambulation speed. So this test is showing not only their walking speed and safety, but also how much they're ambulating at home versus in the community. The other test we did is a 30-second sit to stand. And so this is looking at how many times someone can stand up from a chair in 30 seconds and is a good indicator for their leg strength, their aerobic capacity. So how is their, able to keep their breath during this activity as they go quickly, and their ability to transfer by themselves. And again, you'd want to see for improvement in function that an individual can do more standing up and sitting down in the same amount of time. Typical, in all older adults, not within just the ALS population, but with all older adults, greater than 12 is closer to the average for those without disability. So again, you can see all of our individuals improved during rehab in their ability to get out of that chair with more reps in the same amount of time. I think a big thing to highlight in our rehab approach here, we talked about how it's individualized, how we monitor and measure over time, but is that it's also really team-based. So we have our therapists, but because this is brand new and these individuals have a lot of needs, we're working on a team. All of these individuals are represented here on this circle that we're constantly communicating back with Sean, with the nurses, the other therapists involved, educating family and caregivers of how they can assist, what are things that they should be monitoring. We've worked a lot with assistive technology professionals for different types of bracing and devices to allow individuals more independence. And then also working closely with like advocacy organizations such as you all or the ALS Association to provide the needs that people have and just get people back to those goals that they identify early on in rehab. And pass it back to you, Sean.
Yeah, thank you, Beth. So next steps in thinking about ALS recovery. One is we haven't had this opportunity before to actually do intensive neuromuscular rehabilitation because there hasn't been a drug that had slowed down ALS to a degree where patients stabilize. And so with the advent of Tofersen, it's a start of a paradigm shift in the management of ALS, with thinking about the standard symptom management to how do we optimize patient neurologic and functional recovery. Our study is ongoing. We just added 2 patients. The patients presented here in this paper and presentation all had lower limb onset. And so the 2 additional patients are upper extremity onset. And so we're using different outcome measures and try to find the best one so that we can begin to show that there's improvement. Because as you noticed in the functional outcome measures that we used, there was improvement generally across the board. But if we go back to the ALS FRS, it was essentially the same or showed some mild improvement in 1 to 2 points. And so we need objective and patient-reported outcome measures that will be responsive to ALS neurologic and functional recovery. And then, as Beth highlighted, the need for highly individualized neuromuscular rehabilitation programs based on the varying degrees of functional impairments and activity limitations. And so what kind of proposed is a new model system of care for ALS recovery, where there's prioritized scientific research funding and to set up a multi-site collaborative research platform to work with other centers to seamlessly integrate the clinical and research aspects of ALS recovery. And then there needs to be a consensus definition at some point of what is ALS recovery and what that looks like as there's more disease stabilizing treatments that become available. And definitely need well-designed studies because we want to answer these questions. But for whom is rehab good for? When do patients start? How much? How long? And what type? So currently, the majority of the patients that we presented tonight continue rehab. One of our patients is on 3.5 years of rehabilitation coinciding with his Tofersen treatment. And he continues to make small gains, but continues to do well. So, and Beth, to finish up.
So I think when we take a step back from all the details we just presented, I think overall the SOD1 research and collaboration with the neuromuscular rehab, we're seeing that with these advanced treatments, with Tofersen, having the skilled neuromuscular team, and then working with individuals, family advocacy, and other networks to increase awareness, we hope that we can see not only changes in some of these statistics, but improve patient outcomes and increase that hope within the neuromuscular community, so that as the science continues to develop and we continue to collaborate across these 3 areas, we can turn ALS from a fatal disease to a disease that is livable and manageable. And that is everything we have today.
Thank you.
Thank you so much for this amazing talk and sharing the broader implications as well. We have some questions in the chat from our participants. Alex, do you want to start?
Yes, the first question is, are neurofilament levels routinely measured by neurologists in ALS clinics in the US? And should neurofilament testing be considered a standard part of ALS patient evaluation?
Yeah, great question. It's not a standard of care at the moment. And here under Dr. Bobbicelli in our neuromuscle lab, we've been doing serum neurofilament since 2021. And most of the attendings here have adopted it as a relatively good biomarker to use when patients come in for evaluation of ALS. There's some caveats in that it's elevated in a number of patients with ALS, not all patients. And so it's not a single test to be able to say that the patient has ALS or doesn't have ALS. It needs to be taken in context of the clinical exam, the clinical history of progression, of weakness, and excluding other ALS mimics or other diagnoses that can mimic ALS. But I strongly advocate for getting testing on all my patients when I see them initially, and then through long-term follow-up as well.
Next question we have more specific, if there is any instance that have been reported for a person with the genetic form of ALS, such as SOD1 or FAS, who lost their speaking ability but recovered following the therapy?
Not that I'm aware of with SOD1 ALS and Tofersen. None of our patients had significant speech changes. It's interesting with some of the research that was highlighted here, the Everything ALS trial, to look at some of the speech changes. And I think some of the more recent trials are including software or apps to be able to do that. And then again, we haven't had any patients with it for SOD1 receiving Tofersen with chewing or swallowing issues, some with respiratory needing to be on non-invasive ventilation. So it may not be a fair comparison to kind of overall representation of the ALS population, but I think it highlights that the data that we presented is that there's definite possibilities to improve function in patients who are on disease stabilizing therapies. I am the site investigator for the Fusion study that's looking at the ASO for treating FUS ALS, and so none of that data has been published, and so I can't necessarily comment on that.
Next question, what do you make of the recent data publication from data collected across various Italian EAPs, increasing neuroinflammation biomarkers and inclusive regarding whether treatment slowed disease progression?
Yeah, not familiar with all of the recent publications. There's several studies that we used and cited in our paper that showed similar results of Tofersen in the clinical setting or real world setting, which was a significant reduction in the neurofilament levels, varying degrees of functional of maintenance of function, with some patients potentially, having continued progression, but at a slower rate, and some patients showing improvement. I would say it's right around 20-25% of patients show some degree of improvement. The neuroinflammation is interesting. All of our patients had elevated inflammatory factors in their spinal fluid. We haven't found any clinical correlate to that. And none of our patients have had serious side effects related to Tofersen, which can be increased intracranial pressure, increase in the spinal fluid, or radiculitis or inflammation of the nerves or spinal cord.
Yeah, I think this particular question was linked to increased neuroinflammatory levels following the treatments, and potentially that was discovery or discussion of this paper where they were questioning the long-term effects of the treatment in terms of potential neuroinflammatory response.
Yeah, I can say right now, our one patient is the longest that we've had is 3.5 years in the clinical setting, and there hasn't been any correlate clinically to the elevated neuroinflammatory markers in the spinal fluid.
Next question we have relatively technical, related to Z-scores. So we have a very educated audience here, but basically the question is, when standardized, converted to Z-score, do functional outcome measures such as PIM or ILS-FRS show consistent effect size following the treatment? And can you also explain a bit more for the audience to make sure that that's clear?
Yeah, so due to the small number of participants being 7, and then one of the participants we didn't have sufficient longitudinal data to report on, we basically did descriptive statistics and not kind of inferential statistics, meaning that we're just trying to show and present the data that we found rather than making comparisons. And so the the FIM motor score, functional independence motor score, has been used in several studies in ALS, and there is a correlation between a decline in FIM motor score and a decline in the ALS FRS over time with disease progression. It has not been used to monitor for functional improvement in patients on disease stabilizing therapy. So I think we were the first paper to show that it's a possibility to use this as a measure. And in comparison to the ALS FRS, we saw it seems to be a little bit more sensitive with patient improvement in functional independence than the ALS FRS. So hopefully we can get some funding and do a larger study to answer the question that was posed in the chat.
Someone said, I have SOD1, but I had no one in my family with the disease. Interesting that 6 out of 7 in the study similarly had no family member with ALS. Can you explain why, since I was told by the genetic counselor that the mutation is dominant?
Yeah, so thank you for the question. Yeah, we thought it was interesting as well that the 6 out of the 7 had no clear family history of ALS, and the majority of the mutations in SOD1 are dominantly inherited. At some point, without a family history, it's possible for an individual to be the first to develop the mutation. And so not clear, and that reason why an individual would develop that specific mutation in SOD1. But we're continuing to learn more about the genetics, and I think our study highlights that there's potential that there could be a differential response based on the type of genetic mutation, and so that needs to be an area of research to be able to identify patients who may or may not benefit from Tofersen, or perhaps need additional treatment to fully stabilize their disease.
Thank you. I think next question potentially can be to Beth. Given increased cardiovascular risks in ALS, how does your program take into account these cardiovascular risks and, for instance, specifically maximum heart rate in order to determine the exercise targets?
Yeah, thanks for that question. So we typically start our programs relatively conservatively, and so we use low to moderate intensity. So within the neuromuscular literature right now, that's typically at 50 to 70% of the heart rate reserve. So heart rate reserve is a calculation that we do based on the individual's resting heart rate and their age. So that gives more of an individualized baseline from there. And then, so we'll start using 50 to 70% of that max. And then that's also where we use the rate of perceived exertion. And then for those who have more respiratory involvement, we're also using like a breathlessness scale to look at them self-monitoring. And then we do continuous heart rate and oxygen monitors during those capacity measures. So during the 10-meter walk test, 30-second sit to stand, we're also monitoring that physiologic response. And then we'll dose based on those tolerance. But in general, we've been starting folks conservatively on the 50 to 70%, but we have been able to progress individuals into 70 to 85% of that heart rate range, which is more the moderate to vigorous range. And in general, we use the cardio heart rate response as a gauge of neuroplasticity and neuromuscular control, since I can't go in and do a live EMG or anything to see kind of how much those nerves and muscles are working while that individual. So we use that cardiovascular response, but we do then using that muscle. And then we also monitor during activity, and then we watch that response as well, or rate of recovery. So how long does it take them to get back to baseline based on their vitals response and self-reported measures. And that's kind of how we dose the intensity of the cardiovascular programs.
Thank you. In the context of ALS clinical assessments, which you shared, when performing the 10-meter walk test, is the test typically conducted with the participant wearing their orthotic devices or without them?
Yeah, we've done a measure of both. And so it depends on how that individual, we try and make it as real life to their day-to-day activity. And so some of those individuals who wear I encourage individuals to wear those orthotics, because if I'm prescribed them, that's typically for a reason, for improved safety and control. So if they're not, usually I'm measuring that to gauge safety, but we are measuring those with orthotics over time. And all those measures, they are a great gauge, but they're capacity measures. So they're what they're doing in the clinic and predicting what's potentially happening outside of the clinic. So it helps us get a baseline, get a measure, help prescribe the activity, discuss safety recommendations such as orthotics wear and use. But one area we could probably improve on is getting better performance measures and tracking activity outside of therapy to see how our rehab is really influencing those individuals outside of just the measures we're seeing right in front of us.
Thank you. Next question is related to broader implication outside of SOD1. Maybe you can, both of you can share how do you see the implications to drug development care paradigms, as well as potentially rehabilitation programs, broader rehabilitation programs as well.
Yeah, so thank you for the question. It's kind of limited right now in that there is a minimal amount of information on how to do neuromuscular rehab for a patient with ALS who has disease stabilization. Right? That would be the goal, is that there's multiple drugs that or treatments that would be available to allow for any patient with any form of ALS to have disease stabilization. And then at that point, the question is, well, how can we get your function back? I think it's going to take a lot more than a treatment alone for patients to have recovery and live with ALS. And so we're building the foundational knowledge of what that could look like. And so it's a pretty, I think, decent step in the right direction that patients on a disease stabilizing treatment, Tofersen being the only one at this point, can participate in neuromuscular rehab for extended periods of time and do it safely. And we can progress them, whether that is through resistance exercise with doing different weights, or increasing their walking program, using the technology that's available to allow patients to walk better out in the community. And so there's definitely need for more research in this area. And hopefully by the time that there is a substantial treatment or treatments available, that we can apply that knowledge for patients rather than waiting for that day to come. And so, Beth can speak to this. Stroke rehabilitation has been long researched. And those questions that I shared tonight of for whom, when, how much, how long, is still unanswered. 20 plus years of research. And so we're just beginning this now, and it's probably going to take a while to begin to answer some of those questions, but I think we're making a decent start.
Yeah, I would piggyback on what Sean said. He beat me to it, but I think when we look at the biggest body of evidence right now within neuromuscular rehab, it's typically within stroke rehab, and it's still continuing on, but they're seeing that with the right dosage of therapy, when folks are in a medically stable position, that high intensity rehab can be greatly effective in improving their function even years after that initial injury. And so I think looking at that model, it gives us a lot of hope that we can change our model right now of currently low to moderate, really focusing on maintenance in disease management, to focusing on neuroplasticity and improvement of function, to be able to follow some of that body of evidence for other stable neurological disorders, and even in chronic conditions. So yeah, I think there's a lot of open doors for us to explore, and really exciting for how the rehab team can assist in this really currently devastating disease.
Yeah, and I think it's very applicable because we have actually like follow-up questions on people asking like how do they make these decisions if they taken or their relatives are taking other therapies and they see the slowdown disease. Is it a good indication to try to is it a good indication that you might benefit from rehab programs, or like how should they try to make those decisions for themselves?
Mm-hmm. Mm-hmm.
Our next question is, during the sit-to-stand test and your protocols, is the use of arms to assist in pushing oneself up from the chair allowed or expected?
So the standardized assessment is without without arm assist. However, we do have a few individuals who have been unable to perform that at all without arm assist. I think just one individual actually. So to monitor change over time, we have allowed him to use arm assist because that is the expected means of getting out of a chair that we kind of expect for long term for him based on his current status.
Okay, thank you. Next question is just about the details of like your participants pool and your patients in this study. Do you have only patients which go to WashU clinic, or do you also get some data from additional hospitals?
Yeah, currently it's an internal study of only patients at WashU who follow up in our clinic and are receiving the Tofersen dosing here. Yeah, it's unfunded. The ALS Center and a bunch of individuals who are highly devoted to seeing patients improve, are working on the study. They see Beth and some of the other therapists clinically for their therapy program, and it's a lot of back and forth communication of between Beth and I on exercise prescription, kind of what we think would be appropriate, and working with the patient is very goal oriented based on the patient's goals and their activities of daily living. We would like to expand it, have submitted some grants to do that, and unfortunately haven't had too much luck with funding, but hopefully in the near future we can open it up to other sites.
Thank you.
Next question, what was the time between first and second measurements of function?
I'm guessing the function is based like the FIM score, so correct me if I'm wrong, but we've been keeping all the functional measures for those we've been taking on a monthly basis.
Yeah, and the ones that were shown in the slides, that graph was at their most recent Tofersen dose, and so it varied for all the patients over time. So one patient was on Tofersen for 7 months, and his FIM improved from 86 to 89. And then the one patient was on Tofersen for 30 months or 2.5 years. And he also had improvement from 86 to 89. So we're seeing it in the short term, and then we're seeing that these functional gains are sustained over a pretty good period of time.
Thank you. Next question we have about ATLAS study and specifically potential study which might be happening at WashU, doing a mirror study of ATLAS study. So we have one participant who is presymptomatic SOD1L145F variant. And when the ATLAS study was enrolling, he was told as two variable progression for the inclusion in ATLAS study. So he heard that there is a potentially mirror study, heard from Dr. Buscelli, might be happening at WashU, and wanted to learn a bit more if you know much about these discussions.
Yeah, so for those who don't know, ATLAS is a study in pre-symptomatic individuals with SOD1 mutations. They limited the study for certain variant mutations. And so that's what the question was referring to. And they're looking at when there's a change in the neurofilament, when it increases, or if an individual becomes symptomatic with weakness, of potentially starting very early Tofersen treatment in the hopes of delaying onset of disease, or even preventing the onset of disease. And so that study is still ongoing, don't have any data on it. Hopefully the results will be promising, and that there's the potential, again, kind of looking at the broader implications, is that the sooner we identify that someone has ALS, especially a genetic form or hereditary, that if we start treatment sooner at the time when someone starts to have symptoms, that there's a possibility that we can prevent the onset of ALS, which would be amazing. I'm not aware speaking with Dr. Buscelli of any kind of mirror study, but I will definitely pass that along to him and let him know that we had a question about that.
Wonderful.
And I think our last question, why can't non-gene mutation patients be offered the rehabilitation program at their own discretion?
Yeah, I can field this one. So we actually recommend rehab programs for all of our patients that we see. It's really the difference here is the dosage and how those programs are tailored. So there is good evidence for low to moderate intensity exercise, but we really recommend working with individual or therapists that are familiar with ALS and the disease progression. Because it can be a tough balance to titrate those programs appropriately. There is a risk for muscle overuse and further muscle decline. The biggest thing is when you're strengthening muscle, it can break down those muscle fibers, and then they typically grow stronger. And so with ALS folks with ALS that are not on disease stabilizing medications, that is a risk that we want to monitor. So there can be exercise that's still appropriate as long as it's dosed well and individualized to that person. So here at WashU, we do work with all of our patients. It's just the difference in the dosage. And then basically making sure that that program that's initially prescribed for that person is monitored and changed over time. So we have individuals that come on monthly, 3 months, 6 months, like different frequencies to make sure that the program that they've been given is appropriate to their needs. And ultimately, like Sean said, it's goal directed. So it's personalized to what they want to be able to do, and making sure that it enhances their quality of life.
Yeah, and we have a quick follow-up question regarding that, because everyone is interested about the exercise programs, and it sounds that you have those programs for PALS at different level of fitness and different stages of diseases. Can you recommend how should they approach it? Is there any programs which they can get access to, or do you have any broader recommendations for other PALs who don't have access to your clinic?
Mm-hmm. Yeah, so a really good resource it's a free resource for clinicians and patients, is the Academy of Neurologic Physical Therapy. And it's all neurologic specialized physical therapists. And so there's literature and evidence-based practices for guidelines on exercise of low to moderate. I still highly recommend working with a therapist that has that knowledge base so that they can test and measure where that person with ALS, where their functional capacity is. So there's also a website called Choose PT, and you can search for physical therapists with either specialization with ALS or a neurologic specialization within your area and get connected. So anybody with that specialization is registered, and you can make kind of like a area or radius to find someone within that radius.
Do you mind sharing this resource in the chat? And yeah, so I think we're already getting questions about it, so that would be great. And I think we had a brief discussion, but we have one more follow-up questions about like Tofersen being used prophylactically and how you kind of envision it in the future, if it will be a possibility or not.
Yeah, and so that's kind of what the ATLAS study is hoping to answer, is that at least one of the questions is that if we're able to treat someone who has not yet developed symptoms, but has an increase in the neurofilament, and if we use it soon enough, what is the clinical benefit? And so when that study is completed, that'll give us a lot more information to go on and how to best use Tofersen in treatment of SOD1 ALS. I will also say that there's some interesting research in sporadic ALS that the SOD1 protein is misfolds and contributes to the pathology of ALS. And so it would be interesting to study the use of Tofersen in non-SOD1 ALS patients and see if there's any benefit there. And so I think there's a couple of directions for Tofersen, and hopefully with more ASOs as some of the trials finish up and start reporting out their data.
Okay, I think we answered in time the last question. So that's like amazing resource, and thank you, Beth, for putting those in the chat. It's very, very helpful, and thank you both again for staying with us until so late and answering all of the questions. It was like amazing talk and a great discussion as well afterwards.